Hello there, it's James Southwell-Keely from Wallara Health and Beauty. We're the big blue building on Edgecliff Road, just down the hill from Bondi Junction, train station, bus stop, etc. Love to see you. Today we're talking about breast augmentation surgery. It's a hot topic, it always is. It is in fact the most common plastic surgery, cosmetic plastic surgery procedure performed in Australia and around the world. Now, it's actually a very hot topic at the moment, more so than usual because of the recent discovery of atypical large cell lymphoma, which is a type of tumour that can be found in the capsule or the scar tissue that forms around the implant. But we'll touch upon that later in this discussion. Now, we're talking about the breast in this series. We're going to do a series of talks about different aspects of cosmetic breast reconstruction as well as reconstructive breast surgery. As a small addendum here, plastic surgery covers both cosmetic and reconstructive elements to the surgical pathway. We'll be leaning more towards the cosmetic in this series of talks, but we'll definitely be touching upon the reconstructive aspects of breast surgery as well. So, why do patients have breast surgery? It's a really interesting question. Obviously, there's the necessary breast surgery that we have for obstructed ducts, cancers, lumps and bumps, etc. But there's the cosmetic as well. And the reasons that patients have cosmetic surgery are many and varied. We'll kick through those right away, but first of all, what different types of surgery do I perform and what different types of cosmetic breast surgery exist out there? So we have straight out augmentation, which increases the size, the volume, and improves the shape of breast. Then there's reduction surgery. We have large breasts and wish to be smaller. Following on from that is a breast lift operation, where it's more about the shape and improving the shape and lifting the nipple areolar complexes back more towards the position they once occupied in your youth. There's a mixture of an augmentation and a breast lift, where you need a combination of increased volume as well as an elevation of the nipple areolar complex. And then, of course, combinations of all of the above for breast asymmetries. Maybe one side of your chest wall is underdeveloped relative to the other, or maybe you have an underlying asymmetry in your chest wall, so the rib cage is receded on one side and overly projected on the other, for instance. So definitely asymmetry is a big reason to undertake reconstructive and or cosmetic breast surgery. And then finally, and equally importantly, is reconstructive breast surgery. So surgery for patients who've had mastectomies and wish to restore their normal physiology so that they fit back into their clothes the way they once did and feel whole again and good about themselves. And that's really, really important and an incredibly satisfying part of my work, I must admit. So let's talk then about the different motivations that patients will undertake augmentation breast surgery. So that's to increase the volume and improve the shape of one's breasts. These are listed in no apparent order and come from personal observation and discussion with patients, but also looking on the internet and just seeing what different patients are asking. There's incredible consistency in these questions that are asked. So the first is, and probably most importantly, is self-esteem. Patients feel that they are some way deficient, and the augmentation surgery makes them feel more whole, more comfortable in their own skin. There are lots of different reasons for that motivation, but it's a very successful operation in terms of addressing that issue. Next is asymmetry, and we've touched upon that in the introduction, but sometimes one breast will develop into a D cup size and the other breast will develop into a B cup size. And this makes purchasing clothing very difficult. Patients are very self-conscious about this down at the beach or in the gym change room, and it can really hamper one's social development, and people feel very stigmatized in this situation. Following on from that, there are different congenital problems where patients are born with an underdeveloped breast or tubular breast or constricted breast. They're all similar conditions and or the same condition with different names, but they're variations on that asymmetry with increasing levels of asymmetry or difference in size and shape between right and left breast. Attending to these and making them look as close as possible to one another can be very challenging surgery, but once again incredibly satisfying both for me, surgeon, and for patient. Next is a reduction in size of one's breast. This is another reason patients come to surgeons requesting breast augmentation surgery. There's a phone in the background. It's probably a patient now inquiring about some of these procedures we're talking about now. So here we go. A reduction in size. How does this happen? It can happen with significant weight loss. Just as you've lost weight from your waist and your hips, so too you lose weight from the breast. 50 to 70% of your breast volume is made up of fatty tissue, and it's metabolically active, and as you lose weight from elsewhere in your body, so too do you lose weight from your breast. With this loss of weight, you lose volume like a deflated tire or a balloon that's losing its air, and they become saggy. And accompanying that reduction in volume, you have a redundancy or an excess of skin, and the nipple areola complex, or the nipple per se in the center of that, starts drooping down towards the ground. And so to restore the shape and volume of one's breast augmentation in and of itself is sometimes enough, and sometimes we need to combine that with a lift operation. We've touched upon mastectomy and restoring a patient's feeling of wholeness after cancer surgery, and that's a very important reason for using breast implants. It's not an augmentation per se, and whilst we use similar techniques, the procedure is actually quite different. The risk profile is quite different, and the follow-up is quite different. But in essence, we're using the same technologies to affect the same result, and that's ultimately patient satisfaction and a feeling of restoration of oneself. Patients come asking about, it touches upon their self-confidence and self-esteem issues, but they feel that they are inadequate before the eyes of their partner, and an indirect effect of or benefit from the breast augmentation surgery is an improvement of one's sex life. Now, this is a little bit esoteric and it obviously has never been proven, but it's certainly something that pops up time and time on the internet forums, and patients discuss this with me in my room. So it can't be neglected as an obvious motivation for such surgery. On the whole, I think it's more about feeling confident in your own skin, and if there's something that you've lost or been born without, making you whole again, and so you can live a happy and fulfilled life. Now, let's go back to what I mentioned right at the introduction, and that's this atypical large cell lymphoma. It was on television last night. Tracy Grimshaw presented on this on A Current Affair. It's been in the newspapers, statewide and nationwide recent, and it's certainly been in scientific publications quite frequently over the last 5 to 10 years. It seems to be building ahead of steam. We seem to be learning more and more about this condition as the years go by and further research is undertaken, and in fact a lot of that research is coming out of Australia and specifically out of Sydney. So we're very proud of that, to be at the forefront of the inquiry and investigation of this rare yet emerging condition. What we know today is as follows. It tends to occur in textured implants. So the reason that we use textured implants at all is partly historic, and it was the texturization of the implant was introduced to decrease the rate at which scar tissue formed around implants. We call this capsular contracture. It can cause painful, distorted breasts. Everyone's seen those glossy mag photos of those terribly distorted breasts on celebrities, and in the sensational headlines associated with that, and that often is a reflection wholly and solely of the capsular contracture. So the reason for the texturization was well thought out and was good, and that emerged through the 80s. But we've found since then, through the 90s, the early 2000s, and now into the next decade, that there is a degree of irritation that's caused to the body's tissues through this texturization, and that, coupled possibly with bacterial seeding at the time that the implant is inserted, can together coupled to produce this atypical large cell lymphoma. So there's been a drift back towards the smooth implants. The smooth implants were the first type of implant produced over 50 years ago. And the reason we went away from them in the first place was that they caused a higher degree of scar formation and this capsule formation, hence capsular contracture. but placing the smooth implant beneath the muscle, the pectoralis major muscle on the chest wall, in fact reduces that rate of capsular contraction down to the level achieved using the textured implant. So in fact, it's probably the best bet in this current climate. There have been no cases reported worldwide of atypical large cell lymphoma using smooth implants to date. And so I've certainly heavily drifted towards the use of smooth implants for all my patients. There are some patients that still benefit from the textured surface, and when I use the textured implants, I use the Mentor implants, and once again to date they have the lowest rate of atypical large cell formation, lymphoma formation. So it's something that involves a detailed discussion with patients and then a thorough follow-up before you undertake such a procedure or recommend such an implant, and it really needs to be decided on a case-by-case basis. So by way of a brief prop, there is a smooth implant and here is a textured implant. The smooth implants are universally round. The textured implants were the teardrop implants, which when seen in profile demonstrate an upper pole where it's thinner versus a lower pole where it's thicker. Placed anatomically beneath the skin and into the breast, it was once argued that it created a more natural appearance. That's arguable. You certainly can't see my hand through the textured implant, whereas you can through the smooth implant, because there's the light's essentially passing straight through the silastic shell, and hence you can see my fingers beneath that. In summary then, the smooth implants are never anatomical or teardrop shaped, but if you use a soft gel and place it beneath the muscle, you can produce a very similar effect. That's probably a discussion topic in and of its own right. We can talk about the history of breast implant surgery and the different controversies and problems that we've had over the years, but personally I'm very confident to use the smooth, soft silicone gel implants placed in a submuscular pocket. That's it for now. This has been our first talk from Lara Health and Beauty, myself, Dr. James Southwell-Keely, discussing the breast and breast augmentation surgery. This is the first part of a multi-part series about the breast. Remember, we're at Lara Health and Beauty, that's the big blue building on Edgecliff Road, and I look forward to seeing you soon. Goodbye for now.